Welcome to this week's lecture on Gender and Sexuality, Considerations for Nursing Practice. My name is Tamara Power and I'm your subject coordinator. So in this lecture we're going to look at sexuality and gender. We're going to look at gender and some health statistics, femininity and gender roles, violence in relationships, masculinity and health, sex and gender diverse people, intersex people, documentation, privilege and inclusive practice. So terms such as sex, sexuality and gender are often used interchangeably. Sexuality is a term generally used to refer to some combination of sexual attraction and sexual identity. Gender, on the other hand, refers to a range of characteristics that traditionally refer to characteristics that signify femininity or masculinity. Sexual orientation usually refers to the way a person feels attracted to people of certain genders, in contrast to sexual identity, which refers to the way a person outwardly self-identifies. In a healthcare context, it is important to recognise that a person's sexual identity and their sexual practices may not always coincide. So, for example, some people who identify as heterosexual can engage in same-gendered sexual acts, and this can have significant impact on things like screening for sexual health, as well as mental and social health. Gender impacts on health outcomes and experiences. But gender is a social construct, and the boundaries and meanings are contested and shifting. So in this lecture, I'll first focus on the impacts of gender or more traditional notions of cisgendered men and women. And I will do this as up until recently, the majority of health research regarding gender focused on cisgender experiences. So as well as influencing the framing of health service delivery and healthcare, gender is a determinant of health. This table shows some of the more observable phenomena in this area by illustrating the differences in the types of health problems that are experienced by each gender within the binary of male-female. Hidden within this data are sex and gender diverse people who have been forced into either male or female boxes. Even with such data problems, the table tells us that there are marked differences in the way that gendered health experiences occur. For example, women are more than twice as likely to die of dementia or Alzheimer's than men, but men are much more likely to commit suicide. So while biology and psychology are recognised as contributors to differences in experiences and outcomes, social structure also makes a significant contribution. And it has been identified that women frequently work physically demanding, low-paid, often sedentary jobs, such as those in canteens, laundries, factories and hospitals. This, along with a tendency for women to remain responsible for most, if not all, of household duties, with their accompanying physical and mental strains, combine to create exposure to health risk. Femininity and roles and norms associated with it create further structures that influence health experience and outcomes. And these are often reproduced as sex-based stereotypes, institutionalised in medical textbooks, and attitudes to the female body. For example, the female body is presented as inherently weaker, less affected by cardiac disease than men, less active and less developed than the male body. Further to these traditional norms influencing the perception of female bodies, it has also been documented that medical textbooks frequently compare female bodies to male ones, but rarely reverse the comparison. They construct and confirm male anatomy as the standard, and assume and reinforce the idea that women's primary role is sexual reproduction. In medical textbooks, male is often presented as neutral, superior, and default. So researchers prefer to test new procedures and medications on men so that their findings are not flawed or limited by women's menstrual cycles. And the female body is also subject to medicalisation. Historically, women have interacted with health systems where regular life events have been recast as medical events. Examples include menopause, reproduction and contraception. Male life events are not correspondingly medicalised in this way. In relation to mental health, women have been historically pathologised variously as hysterical, delusional, obsessive and compulsive, among other gendered diagnoses. So often termed domestic violence, family violence or violence against women, violence within intimate relationships is a powerful health determinant. It is estimated that 1 in 3 women will experience some kind of interpersonal violence in their intimate relationships across their lifetime, although the actual number is likely higher due to underreporting issues. Reference to violence includes not only physical violence and threats, but also emotional, economic, sexual and social violence and abuse. Violence in intimate relationships is the leading cause of death, disability and illness for women aged 15 to 44. Interpersonal violence affects not only physical wellness but also mental health, and the impacts of this violence on mental health can manifest in more physical illness through the effects of stress and related conditions. At its most extreme, women are killed by their partners or can be driven to kill the perpetrator in an attempt to escape the abuse. While statistically it is overwhelmingly women who experience violence perpetrated by men, it is important to remember that men can also experience violence and that people in non-heterosexual relationships also experience violence in intimate relationships. The foundation of this violence is control and abuse. Awareness of the impact of traditional dominance of men over women is important and should inform your understanding of the predominance of women as those experience violence at the hands of men. However, do not let this close your eyes to certain ways that power and control can manifest itself within intimate relationships. For these reasons, it is important to routinely screen for violence. Given the prevalence of the problem, best practice is to include at least basic questions in intake forms or conversations, and to probe wherever your judgment suggests that further inquiry is necessary. Making appropriate referrals to mental health professionals, social services, and related health providers may be required, but this should be done in consultation with the person and in a way that does not expose the person to more danger and abuse. While much focus within the field of gender and health is on women, it is important to also consider the impacts of masculinity on health. While male bodies have been privileged as normal, much of this has occurred without conscious thought, and as such, masculinity in health has been neglected in a similar way to femininity in health. Just as women can be typecast into traditional roles, so too men can feel limited by what society expects of them. So you remember from the online quiz and tutorial content, cisgender refers to people whose gender identity matches the sex assigned to them at birth. So cisgender has its origin in the Latin prefix, in the derived prefix cis, meaning on this side of, which is an antonym for the Latin-derived prefix trans, meaning across from or on the other side of. In the case of gender, cis is used to refer to the alignment of gender identity with assigned sex. So cisgender men are typically less likely to have regular checkups and more likely to delay seeking help when they feel unwell, in part due to gender roles and expectations. Life expectancy for cisgender males is lower than that of cisgender women, and cisgendered males have higher mortality and morbidity rates than cisgendered women. It has also been suggested that cisgendered men have lower health outcomes and higher rates of disease and illness, in part due to their health behaviours including higher consumption of high-fat foods, higher smoking rates, engaging in more risk-taking and life-threatening behaviour, not engaging with their general health practitioner and preventative health services, or not acknowledging and seeking treatment for emotional distress. So Western culture has come to view gender as a binary concept with two rigidly fixed options, male or female, both grounded in a person's physical anatomy. When a child is born, a quick glance between the legs determines the gender label that a child will carry for life. But even if gender is to be restricted to basic biology, a binary concept still fails to capture the rich variation that exists. Rather than just two distinct boxes, biological gender occurs across a continuum of possibilities. This spectrum of anatomical variations by itself should be enough to disregard the simplistic notion of a binary gender system. The gender binary is problematic for people who do not feel that they fit neatly into either female or male boxes. Sex-based social structures also serve to inform the social construction of gender. So put simply, gender is not tied to genitals. One example of alternative ways to think about gender is that of the Bugis Society in Indonesia, which recognises and understands 5 distinct genders. Their language offers 5 terms, referencing various combinations of sex, gender and sexuality. And I won't embarrass myself by trying to pronounce the Indonesian words, but they loosely translate to female woman, male men, female men, male women and transgender priests. So generally at birth, a person is categorised as male or female unless there is biological ambiguity about a person's sex. This is usually done unthinkingly. This process is sometimes referred to as assigning sex. Not everyone's gender identity matches the sex they were assigned at birth. Some people who feel discord identify as trans or intersex. The social construction of gender is also informed by these gender binaries and creates roles and expectations for women and men. Sex and gender diverse people often do not fit within these roles and expectations, and this can be a source of discrimination and exclusion. Not everyone that does not conform to the gender binary identifies trans. Some people feel as though their gender is fluid, and as such the way they express their gender may change. This fluidity can be important in all contexts, but especially when medical treatment or preventative care may require addressing biology that does not align with gender identity. For example, pap smears for trans men, or contraception education and access for trans and intersex people. Another critically important aspect of sex and gender diverse inclusion is the use of pronouns. If a person makes it clear they do identify as male or female, be sure to use the corresponding pronouns. Many sex and gender diverse people do not identify as male or female, and as such do not identify with the pronouns he or she. So if you're not sure, politely ask the person how they would prefer to be referred to. And listening to the way the person refers to themselves can be a good start. So intersex people have distinct needs and should not be confused with trans people, despite much overlap in the concepts that underpin the deconstruction of gender norms. Intersex is an umbrella word that refers to people with sexual anatomy that does not fit within the labels of female or male. Intersex people can be particularly susceptible to medicalisation and stigmatisation, and there is often pressure for normalisation to fit the person back within a normal biological box. So language is therefore particularly important. Best practice includes working with people and their families in order to defer permanent decisions about treatment until a person is old enough to consent to such treatment themselves. So common problems faced by intersex people include osteoporosis, access to appropriate medical specialists, sexual dysfunction, and issues related to hormone replacement therapy. So intersexuality describes variations on sex definitions related to ambiguous genitalia, gonads, sex organs, chromosomes, or hormones. Transgender and intersexuality are gender categories, not sexualities. Transgender and intersexual people have varied sexual practices, attractions, and identities, as do cisgender people. So how many times have you attended some sort of service and the first thing they do is hand you a clipboard and get you to fill in a form? So documentation and forms are often one of the first interactions that people have with health services. They send powerful signals to people about inclusion or exclusion. Inclusive documentation uses the kind of language we've been discussing this week. If our forms are inclusive, we have a unique opportunity to ensure that we gain a fuller picture of a person from the outset of their relationship with the healthcare provider or institution. LGBTIQ plus people, just like Indigenous people, will screen services for inclusive practices, meaning that signage, written information, and initial interactions with non-medical staff, such as receptionists, can shape the decision to engage with a health service or not before the person has even met a health professional. So I just want to raise some issues with forms that only provide the options of male or female. The assumption is that people who tick female will have XX chromosomes, a uterus, a vagina, stereotypically female hormone production, and the capability, depending on where they are in their lifespan, to become pregnant. Yet this F category tells us very little that is medically useful. Human physical diversity transcends popular stereotypes. So the following is an example taken from the LGBTI National Health Alliance white paper on data integrity gaps in Australian standards for collecting sex and gender information. Consider the case of a man born with a stereotypical female body who was assigned female at birth. Since having various surgical interventions to affirm his gender, this person now has no ovaries or potential to become pregnant, a typical male hormonal profile and a typically male distribution of hair, fat and muscle. He also has a typically male face and voice, hormonally enhanced erectile tissue he considers a penis, and a uterus. He is likely to consider himself male and scientifically should be treated as male in some areas of medical data collection. However, he may still have a uterus, so he might not be stereotypically male in some physical aspects. So on a survey that merely asked people to indicate male or female, someone with this physical profile might select male, female or neither. And how would this data be useful? So alternatively, some recommend a two-step approach to this type of question, inquiring about gender identity as well as sex assigned at birth, although even this may be slightly problematic for intersex people. So privilege theory has been developed as a way to highlight the operation of social structures that confer unearned advantages on people with particular attributes, such as being cisgendered, male and heterosexual. Privilege does not mean that cisgendered or heterosexual people have done bad things in order to gain this privilege. Rather, it is a reflection of the complex social structures that reproduce these seemingly natural advantages that are conferred on people who fit within a privileged identity. And it is important to view privilege with an intersectional lens. A person may be male, but not heterosexual. And there are a variety of other factors that can operate to either privilege or oppress, such as age, class, area of residence, and disability. So look at the few examples of cisgender privilege on the slide, and can you think of any more? So perhaps the most fundamental aspect of a person's identity, gender, deeply influences every part of one's life. In a society where this crucial aspect of self has been so narrowly defined and rigidly enforced, individuals who exist outside its norms face innumerable challenges. Even those who vary only slightly from the norm can become targets of disapproval. Yet this does not have to be the case forever. Through a thoughtful consideration of the uniqueness and validity of every person's experiences of self, we can develop greater acceptance for all. Not only will this create greater inclusion for individuals who challenge the norms of gender, it will create space for all individuals to more fully explore and celebrate who they are. So when discussing gender and sexuality, the language you use is critically important. Be aware of both your own communication and that of the organisation you work for. Critically reflect on how people are received and what sort of first impression they form of your organisation. Advocate for inclusive practices, including data collection and documentation. Challenging your own privilege assumptions and biases is difficult and requires hard work. But as nurses, we need to develop inclusive practice. This is not only working to prevent exclusion, but also welcoming, embracing and respecting all people requiring healthcare. And it is more than mere tolerance, it is respecting the dignity and humanness of all people you interact with in the context of your professional life. And here are some references for you. And as always, thank you for listening.